presentation. I'm going to share the screen. Okay. Do you see the presentation?
Yes, we do. Thank you, Sylvia.
Okay. Today we're not talking about everything about harm reduction because we could discuss for weeks probably, and we are just going to dig in the first few steps and the basics. So we are going to start with a definition, a brief historical introduction, a little bit about the philosophy and principle, how to implement harm reduction, and the language to use. Feel free to interrupt me if you don't understand something, if you want me to talk more or explain better. So there are a lot of different definitions of harm reduction, depending on the law of the country, on the legislation, or the organization that is doing that definition. But the one that I prefer most is the one from the Harm Reduction International, which is an association. You can see the link. You can look for them up in the internet. There are a lot of different tools and documents about harm reduction, really interesting. So when we're talking about harm reduction, we refer to policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policies, and drug law. Harm reduction is granted in justice and human rights. It focuses on positive change and on working with people without judgment, coercion, discrimination, or requiring that people stop using drugs as a precondition of support. As you can see here, we mainly talk about drugs, but in the last few years, harm reduction really became a model that we can use and adjust with other risky behaviors, such as sex work. So I'm going to mainly talk about drugs, but just think that the same principle can be adapted in other situations, and maybe in the second part about the question, if you want to dig in another topic, we can do it for sure. Before starting, I want to talk a little bit more about what we think drugs are and what they really are. So drugs are substances that when we use them, we consume them, they produce a biological and psychological effect in our body. The first thing that come up in our mind usually when we think about drugs, it's bad things that are dangerous, like heroin, crack, but actually cigarettes, alcohol, benzodiazepine, coffee, sugar are other drugs that we use in our daily life. So an exercise that I always think is useful, at least for me, it's when I'm talking with someone that is using an illegal drugs, try to think the same things about alcohol or cigarettes. We don't ask someone to stop drink alcohol or stop smoking cigarettes in order to access services. But we do it when we are talking about cocaine or heroin. A lot of people think it's because they are more dangerous, but actually there's no real line in the dangerous and safe drugs. Alcohol is one of the most dangerous drugs, and it's really easily accessible. In some countries a little bit less, but we can all use it and consume it. So when our mind is going to judge someone because of their use, or when we are trying to look up for strategy that we use or we want them to use, let's think about us and let's think about how we can manage how we manage our alcohol consumption, how we manage our cigarette consumption, how we manage our coffee. It's we're going to come back to this, but it's something that I wanted to put in the beginning to just think about, because it's really useful for me when I work with them to go on what I use, what I consume daily, and what can lead to an addiction, and how I do harm reduction with myself without really knowing and acknowledging it. So a brief historical context, I think It's really important because harm reduction is a methodology that was born and created by people that use drugs. So it's really made by the people for the people. And it's something really important. Harm reduction is a really, is not that old. It's the first heroin prescription were in the early 20s, but it was just a few in a small country, in just some small experience. Also the first methadone programs in the 60s and the 70s. They were the first step of harm reduction, but were not really used and not in a lot of countries. When the harm reduction really started was during the 80s with the HIV pandemic, where a lot of people that were injecting drugs realized that they were testing positive to HIV. And they start to advocate in order to have safe ways to use drugs and don't get HIV and not get sick. So they started to organize themselves in the Netherlands, and they managed to open the first needle exchange program. They were able to get first rapid test of HIV in order to get the diagnosis the earliest as possible and the fastest possible and start the treatment. And in 1986, the first consumption room opened in Switzerland. During the 80s and the 90s, the harm reduction program started to spread out in all Europe and other countries in different ways. So some countries had more services, others had less. But it started to spread out because people were seeing that it was working. And people were using the methods of harm reduction. There is something that they were not doing with other methods, or they were struggling more. So in 1995, opened the first the European Observatory on Drug and Drug Consumption in Lisbon. That is an observatory that exists. It's from the EU. And their website is also another good tools to research also about your own country, because you can look for your own country or Europe or topic in general. In the 1990s, we have the first harm reduction convention in Liverpool that finally started to define what harm reduction is, how it works, what we can do, what people need, what they want. And in the 2000, the harm reduction has been recognized on a European level, and it's been in the legislation of European Union. And from them, countries started to put in their legislation and open up more services and organize it and have indicators to work with. So before to go to what the philosophy is, I said a little bit about the principle. I will ask you to go to this link and put the code, the 67246917 that you can see on the slide, and share what do you think are the principles of harm reduction. What do you think is the way that the harm reduction work? What we have to have there.
And I've also added the link back into the chat with the code for people to copy and paste in case you came into the meeting after and you can't see the history in the chat. Just for we had 1 or 2 people just join from the waiting room. So in the chat box, there's a Menti link and a code, and you can just put in hit the hyperlink and put in the code, and then you're taken to a page where you can put in words that you associate with harm reduction. And I think for this stage, there's no right or wrong answer, but it's just an opportunity for Sylvia to get an idea of what are the attitudes towards harm reduction. And I can see, Monica, you've also just joined the room, so I'm putting it back in again, because I don't think when you join, you can see the full chat history. Sylvia, do you want to say maybe a few words about what you're seeing coming up on the screen?
Yeah, actually, I'm seeing a lot of things that I put in the next slide, so I'm happy we are going in good direction. The main word that I see here is health, and not judgmental, but also we can see client-centered services, conscious consumption, helping, dignity, pleasure, trust, risk reduction, empathy, helping, safety, legal and not legal drugs, self-determination, decreased danger, participation. I think I said them all.
Yeah, I think health and non-judgmental seem to be the two ones.
And actually, health is what started harm reduction, and is always been the main topic since the beginning. When we, I will come back to my slides. Okay. Actually, a lot of you already mentioned what are the main principles, so I'm really glad that a lot of you already know and probably are already using this principle and this philosophy. As most of you said, health is the reason why harm reduction started, and it's not, when we talk about health in harm reduction, it's 2 ways. Is the individual health for the person to have a safe use and don't get any infection and have knowledge about the drug, but also is a collective health. So to avoid to spread diseases, to avoid to have dangerous situation, and it works both ways. Then it's a human rights-based and evidence-based philosophy. So a lot of times when we work about drugs, we use approaches that are not evidence-based, such as prohibitionism. We tried it a lot of years, it's not working. We don't have evidence that this is working, but we are still insisting. With harm reduction, it's not the same. Every method of harm reduction is being studied and tested, and a lot of research about it, and we have proved that it works and why it works. There are a lot of papers about it. Harm reduction doesn't use methods that are not evidence-based. Also, as also a lot of you said, we work with no judgment. When people come to our service, come to us, and they have a drug use or they're doing another risky behavior, they know that that is risky. They know that that is dangerous. A lot of people already told them that they should not use drug, or family, friends, other services, they know it. They don't need us to repeat it. They don't need us to say that drugs are bad. They know it. And if we do it, we just make them re-experience the same trauma that they had in other places, or just the same refuse for help. We have to not judge and to allow the free choice. We have to give information and tools for the person to be able to have an informed choice, but we have always to remember to not judge the people and let them have a free choice. Because in the end, if a person wants to die of overdose and with a lot of infection, is their own choice. As far as the person have the tools to make the choice, is their choice. Sometimes as a professional, it's hard to understand it, because of course we don't want them to die, we don't want them to be sick, to get sick, but it's their choice. And we have to be comprehensive and accept. Sometimes it's hard. We have to do a lot of work on ourselves to deconstruct the stereotypes that we might have. Drug and sex work are things that we also grow up thinking that they are bad, they are dangerous, we don't have to do it. And stereotypes are in our head, and we have to make sure that we deconstruct them and we are able to pass the information without judgment and accept everything and comprehend. This is also really important because, as a lot of you said, it's a person-centered approach. If we don't comprehend the person, if we don't accept the person, we're not going to be able to do anything, because we have to work on what the person wants, what's their goal. I'm not saying that abstination of drugs is not the goal. It can be, but it's the choice of the person to stop using. It never can be our choice. And we have to find methods that work for that person, for the needs of the person. Everybody takes drugs for a reason. We take our morning coffee to have more energy, and our client take another drug for another reason. We have to work on the reason, we have to work on how this person is the routine, what they can, what we can help them to do in their daily life. I always, when I talk about this, I'm always thinking about there's a filter to filter benzodiazepine enabled to inject that is really complicated to use and requires a lot of equipment. It's a great tool, but nobody will use it because it takes a lot of time, a lot of tools. So it's a great idea, but it's not going to work if we don't make it accessible to the person. And we have to empower and go to promote autonomy of the person, because in the end of the day, we are not going to be there all the time. The idea is to not be there all the time. So we have to work about proximity. And when we want to use harm reduction, we have to have these 2 points in our head: proximity and low threshold. For the same reason that I said before, we have to make it accessible. We have to make people be able to come to us. So we cannot have a lot of rule of access to the service. We cannot have opening hours that doesn't work for our people. We cannot have our place of work in an area where nobody is going. We have to be there. When we opened the drop-in in our service, we open it in the parallel of the street of drug dealers. So that's where the people are going to use it, because you buy and you go to look for a needle. If you put the drop-in in the city center, in a city center, in an area that people are not using, in a fancy area where just rich people live, people are not going to come to you. And if they are not coming, they are not going to use the things that they need. So how we do all of this? There are different methods that have been used in the last year and created. So as I said in the brief historical context, the needle exchange programs. Needle exchange is really important to don't make people sharing the tools and get infections. What we do in Portugal, we don't just stay on the needle exchange. We provide injection kits, smoking kits, and sniff kits to help the person have all the tools that they need to make a safe consumption. We don't provide the drugs yet. Some countries does. Switzerland does it. But it's really important to provide them. not ask for money for it, because if you ask for money, they're not going to use it. In Portugal, we are lucky because at least the injection kit is provided by the state. So it's free for the organization. It's something that is not the same in other countries, but if it's not, it's important that we advocate for it. Another tool is drug checking. This is illegal in a lot of countries in Europe, unfortunately. In Portugal is legal, but as I said, we have to make drug checking accessible. What is drug checking? Drug checking is a way to check what there's inside the drug. Coming back to the drug picture in the beginning, when we buy a bottle of alcohol, we know what there's inside that bottle. We know the amount of alcohol that's inside and the ingredients because we have a label. When we buy crack, heroin, marijuana, benzodiazepine in the black market, we don't know what there's inside. And it's important to check it, to see if it's safe, to see how high is the amount of the drug, and to inform. But we have to make it accessible. When the first drug checking opened in Lisbon, it was really it was a place with just few opening hours, and they were giving the result of the test 4 days after. This is something that really works with people that are use drugs in a recreative context, such as parties and festivals, and they're organized enough to wait for 4 days. People in situation of homelessness, young people that are starting, they probably don't have a lot of money, they will not wait 4 days. So what we did, we started a collaboration with them, and they were able to get a machine that gives the result immediately, and in a van that could come to us or come to the street. So people could go there, have the drug tested, have the result immediate, and decide then immediately if they are going to use it or not. Then we have the treatment of opioid antagonists, such as methadone, Subutex, in some countries also heroin. This is the most used. I'm not going to talk a lot about it because I think most of the people already know, but if you have questions, of course, we can talk about it later. Community naloxone. So for the one of you that doesn't know what naloxone is a medicine that can revert overdose from opioids, such as heroin and morphine or fentanyl. Before was an injection, was not so easy to carry, but now, as you can see in the picture, is like the things when you have a cold and you need to put in your nose to be able, in order to be able to breathe. It works the same, but can revert overdose. It's really important that we always carry it with us. We, of course, doing trainings, and then we always carry it with us, and we make sure that people know that we have it. I work in housing first. I always have it with me. I usually teach people how to use it, and if they want, they can. I give it to them. And we have to make it communitary, because it's something that it's really there is in hospital and ERs, but in the end, the community is going to be there when the person is having overdose. So it's really important that we provide trainings for the people, for the drug users, and we give it to them in order to be there and be able to use it, even if they don't have it enough to revert an overdose. At least it can help until the emergency professional arrives. Education is really important. Talking about drugs, talking about the risk of it, talking about how to have a safe experience, how to learn how to dose, how to control the assumption, how to have better way. We do a lot of education in different ways. As here you can see flyers. Unfortunately, we have most of them in Portuguese, but our partner Cosmicare, they also have them in English. When we did those flyers, we did it with our clients, together with them, because the most of the time when we look for information about drugs, it's a lot about medical books or psychologist books. Is a difficult language for the most of the people. So what we did, we worked with them in order for them to help us explaining what a crack is, how it works, we can make it safe with their words. Peer educators. Peer educators are really, really important. In our services, at least 50% of the team is made by peer educators. Peer educators are really important in both ways because they work with the team that comes from university, comes from educational environment, and doesn't know the environment. We know the books, but we don't know what it's really going on. And they really help us to learn the language, the places where people are using, to see what's changing in the environment, to deconstruct our stereotypes, to learn how to communicate better. And they are the best in communicating with the clients because they speak their own language. They can build empathy, and that as us as professional, it's harder, and we need them to work, to make a good work with these people, and to make people in situation of homelessness trust us, because we know, all of us know that trust is a big issue with this population, and peer are the best in helping us building trust. And they are also really important to do outreach. Outreach is when we go in the field. We go where people are using, where people are sleeping, where people are living, where people are staying, to talk with them, to understand where they are, to take the service to them. This is really important, but I will say never do it without peers, because it can be, it can look judgmental. It can look, I come from the university, I study, I know what is best for you. And even if we don't have this attitude, it's really hard to make sure that the person is not feeling it, because actually we are from the university going there. And if we have peers, this make it easier. And also they know where to go and where to find people. Safe consumption room, I'm not going to talk a lot about this because we have a next webinar, but they are really important to provide the most safe environment as possible, and with a trained team there, able to revert overdose. Right now, we have medication to revert every type of overdose. So people should not die of overdose, and we should work best to avoid it. These are two pictures of the safe consumption room that we have in Portugal. And the one on the right is a mobile consumption room that is going in the street to make it more proximate. And then advocacy. Advocacy is really, really important in all directions. Advocacy with the people to deconstruct the stereotype that they have on themselves, and to make them able to be more empowered. Advocacy through the policymaker to change the laws, to allow us to do our job, to make drug use safer and more open. Advocacy through the community to start change the stereotypes coming back. These are two actions that we did in the last year. One on the left is for legalizing marijuana. We are not there yet, but we are doing our best. And on the right is the Support Don't Punish event. That is a campaign that happens every year in June. I think it's on the 20th, I'm not sure, but it's a funded campaign. So if you have ideas of events or something that you want, there's a call of application where you can have funding to promote support and don't punish about drug use and people in situation of homelessness. And then I want to, we're in the end, I want to talk a little bit about the language. A lot of time when we talk, we say drug addict, alcoholic, junkie, dope head, and let your fantasy go. There are a lot of different words that people use. I don't think they are the best because it comes first the substances and the disease, and then on the end comes the person. We prefer always to use people who use drugs because the person comes first, and then their use is just one part of their lives. Instead, when we say drug addict, we make the drug and the use the main part. And we are, again, putting the stereotypes. We don't say addiction, we say drug use problem, mainly for two reasons. Addiction is a medical word, so that is not judgmental per se, but it became judgmental in the last year. Addiction is something bad, something that you should not have, and scares people. And also we are not, most of us is not able to do a diagnosis if the person is having an addiction or not. We are just assuming of things that we don't know for sure. So we always talk about drug use problem. We don't talk about drug abuse, we talk about drug use. It's always to deconstruct, to make it open, to make it okay to talk about it. We never say be clean, because when we see a person got clean, it means that before the person was dirty. And drug use doesn't make someone dirty. So we prefer to use be sober. We don't say opioid substitution programs, but treatment of opioid antagonists, because they don't have to substitute the drug. You can have methadone and you can still use heroin. If it works for you, if the best way for you to don't have too much heroin, that's okay. And we never say rehabilitation, rehab. We always prefer to use recovery, progress, and treatment, because again, rehabilitation means that the person was not able before and just got back. So we try always to destroy, because it's not black and white, it's not bad and good. It's just a part that can become another. But as you can see with most of the drugs, we can have a safe use of drugs. We can have integrated consumption. This can also be an option. As we drink alcohol in evening when we go out and we drink a beer, and we know that one glass of beer is safe, and we know that probably 10 are not the best idea. That's what we have to do with the other drugs. It's education, but we can have a consumption of drugs, even heroin, even crack, and still have our life and still have to go to work. We have a lot of clients that going to work and they tried to stop and it was not working. And when they were trying to stop using crack, they were craving so much and they will start just go back and using a lot and lose their job. And when they finally find the balance, they could have a normal life and going to work and do their things and still smoke crack. And it's okay. If it's what the person wants and what it works for the person, that's okay. I don't know if we still have time, but I will leave here some phrases that you will hear, you probably already heard about, like people saying that about against harm reduction. I don't know if some of you wants to try to answer some of these or already heard some of these phrases and wanted to reply to them. It's something that it's good to have an answer to all these questions or phrases that people are going to tell you. And also it's important for you to go back to your ethics, go back to find your limits and find what's okay for you to do, what's not. Harm reduction can go in a lot of different directions, and some of these are probably questionable and can have a lot of ethics problems. It's important to interrogate ourselves and find an answer before having to deal with the situation and not really know what to do. But it's also okay if it happens. And yeah, I don't know if some of you wants to try to reply to one of these phrases, or if not, it's okay, we can just finish here.
Would anybody like to jump in and to take one of the phrases on the slides and have a response? Or does somebody see one of the phrases and think they don't really have a response if they heard something like that being said in a work context or with one of the clients that you work with?
Hi, I'm Beatrice from Italy, and I've seen different I've heard different phrases that I'm reading now, but the one that I find it more difficult to reply to would be methadone is like exchanging a drug with another one, because the drug services in Italy are very much kind of focused on methadone programs rather than harm reduction. So this is something that I thought, like, if you center the service on just giving people methadone and checking their urine and checking that they are not using, and this is obviously is not a harm reduction kind of policy. And so sometimes I find it difficult to think of methadone as actually just a tool to an end. But it looks like is the only focus of a program, or yeah, that's it.
Yeah, so methadone is actually another drug, but it works different because it stops the cravings, but it doesn't have any effect. So this helps because the person, it helps the cravings, but works also on not to having the effects. So when we work with methadone, we can also work what the person was looking in the drug. They wanted to get high. Why? They wanted just to sleep in the night. They want to just inject heroin and fall asleep because it's the only option for them to fall asleep. Okay, then we can work on this of the sleeping problem without having to deal with the craving. So I'm not saying that harm reduction is the only solution. Harm reduction is one of the possible methods to use with the person, and actually other type of methods to work with the programs works with other people. So maybe someone needs to get the urine tested in order to like have this control to be able to stop, because they want to stop, and if they don't have this type of control, they will not. Something that can work for them, and it's okay. But yeah, methadone takes away the craving. It's something that works with a lot of people because it takes away the craving, or put a routine in the person that it's when they're going to use it. At least in Portugal, the methadone that is given in vans that goes to around the city, everyone has a specific time in the day where they have to go. They can go in other times, but most of them are really that day, that time. And it gives a control, an organization, a routine, stop the craving, and allow them to then start a small reduction of the amount with a medical control. That's something that works with people. Is exchanging a drug with another one? I'm not going to say that, because methadone doesn't have any big effects. It calms down, get people sleepy, but it's not a fun drug. It's not fun to use it. It also tastes awful. But it's a great method to control and reduce the use. It's not the only one. You can do instead of methadone, you can do Subutex or heroin, if it's allowed in your country, of course.
Thank you, Sylvia. It's difficult to see everybody because of how the screen is shared. So if you have another question or comment that you want to come back to on the phrases, if you want to put the slide back, Sylvia.
Yeah, I just wanted to say these are my contacts. So if I can share the slides with your Robbie already have, but if you have like more resources, or you want more a link to where to dig in and more topic, you feel free to contact me. These are my contacts. I can also put them in the chat. Yeah, if you have questions and you want to learn more about something, feel free. I don't always reply in the same day, but I always get back to you people.
Great. Thank you very much, Sylvia. That was really, really helpful and a really good grounding to understand what is harm reduction. And maybe just worth saying again that next Thursday, we have another webinar, which is focusing on consumption rooms. So looking at how to set up a consumption room, how do they work, how does it fit with harm reduction? And then after that, I think we still have to confirm a date, but we will do another harm reduction webinar, which is looking more at harm reduction and women's homelessness as well, with my colleague Dalma. But part of what we wanted to do today, because this was a webinar that was suggested by the Fiancé Youth Network, was to talk about how can we take some of these principles around harm reduction and how do they apply in a youth homelessness context. And so, Sylvia, not to put you on the spot, but do you have any suggestions around how do you take this model that is used historically around drug use and apply it to how we work with young people experiencing homelessness?
So most of young people that are experience homeless don't have no tools. They are just experience homeless for the first time. They don't know the service. They are not linked to the service. They are just being kicked out of the house of another place where they were staying. So most of them has a lot of stereotypes in them against the drug. A lot of them feels guilty about the drug use. So the first thing that I will suggest is to make a safe space, to make it an open conversation, to say that it's okay to use, it's okay to use a lot, it's okay to don't use the methods to use, and give them all the tools and help them assess the services. But yeah, we have always to remember that the trauma with these people is still really early in the days. So they are still feeling it a lot, and we have to be careful and not scare them away. Always, like, it's more or less the same that I said before, but even harder, because it's something that just happened probably, and they just have been kicked out. They just lost the family, friends, the community that they knew, and we have to make them see that there are people there. Then we don't have any rules. We have a few rules, but not linked to the drug consumption, and really sit with them, let them feel okay. Don't push the conversation. It's okay if the person is saying I'm not using, and we know that they are using a lot. It's really important to make okay every type of conversation, and give the person the time to explore, give the person the time to know you, and know that, make sure that you are not going to judge them. It's something, what I feel useful is, like, if you work in a drop-in or in a closed space, make sure on the walls that people can see your ID and where you stay, that you are against prohibition, that you are not going to judge them. For me, it worked a lot, because as I was working in a drop-in before, and then I moved to housing first, a lot of people already knew me from the drop-in, so already knew where I was standing for. And they don't hide the drug if I come in the house. If they have the drug on the table, it's okay. Actually, it's a great opportunity to talk about it if they want. So I think also it's good to have a discussion with the person and let the person know where you stand for. Even if that doesn't lead to a conversation, at least the person knows that you're there and you are not going to judge them. You're not going to try to make them stop using drugs or another risky behavior. And you are there to help them, getting all the tools that they need. Also really important is to give condoms, internal and external condoms, and lubes. That is something that really important for everyone, but mainly for young people. Is something that also can engage them, because it's something that they get for free. To use for something that it's fun. Work on the drugs are pleasures, and it's not bad. So also work on that. how to still enjoy in a safer way. And always remember, the trauma is really still there and it's burning, and be delicate. Maybe with the postcard about trauma-informed care can also help. But don't insist to talk about it. We don't have to do it. If the person doesn't want to, they will do it in their own times. But yeah, if you can, I don't know, put a pin saying, I don't know, harm reduction or human rights, something that just show where you stand for, and that it's a safe space for have an open conversation.
Okay, I think there's some very helpful tips there around taking the time to build trusting relationships, not just in how you speak, but in the design of the space, that it feels welcoming. There are signs and signals on the surface and the walls, on maybe your name badge, things like that, that tell them it's a safe space for them where you can talk about these conversations. And always being very mindful of trauma as well. I'm going
also like, in a housing first context, at least what works for me, it's okay if the person has drug on the table, if the person, if I'm trained for it, so if the person wants to smoke during the time I'm there, so it's a good opportunity for the person to not be alone. But also find your own limits, how far you can go. I don't allow people to smoke heroin with me, because otherwise I will get also. But with other, like crack is okay. So find your limits and
set your boundaries.
And look a lot in the environment. If the person is leaving the drug on the table, or it's opening the door with a syringe in their hand, it's a good thing now, at least for me, because it means that they trust me enough to just leave it there, and it opens a conversation. So also see if the person is opening a conversation without saying it. It's a little bit hard, but like if someone opens you the door with a syringe in their hand, it means that it's okay. They don't have any problem in showing it to you, and it's a great way. Okay, let's start discussing needle exchange. And also, if it's possible for you, let them know that you have the tools with you. I always carry naloxone, I always carrying an injection and a smoke kit. So if the person wants to ask me, I can just give it to them. I don't carry condoms, but if they want, I can give them in just a few hours. Let them know that you're there and they can talk to you. They will come.
Thank you, Sylvia. I'm going to just stop the recording now so we can have the more conversational side of things.